Sir, I think we can start. Good evening all. Welcome to the 8th webinar of AOMSIKerala State. Today's topic is Nuances of Orbital for Reconstruction. Our faculty for the day is Dr. Karthick, Ramakrishnan, and our moderator is Dr. Binu, Augustine, Head of the Department of Oral and Maxillofacial Surgery and Dentistry in Rajagiri Hospital, Kochi. I request Dr. Binu, Augustine to introduce our speaker for the day, Dr. Karthick. Over to you, sir.
Sir, you're on.
Your microphone is muted, sir.
Hello. Good evening, all. It's my pleasure to introduce Dr. Karthik Ramakrishnan. He has done his BDS and MTS from Annamalai University. He's a professor, Department of IMFS from SRM, Kakalathur, Chennai. He's currently into private practice. Over to you, Dr. Karthik.
Thank you, sir. On the outset, I would like to thank Dr. Akhilesh and AOMSIKerala for giving me an opportunity for the topic which I always have an interest on. So let us straight away move on to the topic of today. As I asked Dr. Akhilesh what is our target audience, he said it is a mixed crowd, which means basically both postgraduates, beginners, and experts. So I have included some amount of basic stuff and some amount of surgical stuff, some amount of advanced stuff as well. To start with, we all know the orbital cavity as such is a confluence of 7 bones, namely frontal, zygoma, sphenoid, maxilla, lacrimal bone, ethmoid, and palatine bone. So it is of paramount importance to know the osteology of orbit, which has got 4 sides: the roof, medial wall, lateral wall, and the floor. We have to understand that a roof or any other wall is not a single bone. It has got 2 to 3 bones together. For example, the floor is made up of orbital process of palatine bone, which is a small bone on the posterior aspect of the floor, orbital surface of the maxillary bone, and the zygomatic bone. It is not only important to know the osteology of orbit, but it is of even more importance to know the soft tissue components of the periorbital and orbital region. So what do I mean by soft tissue components is that the periorbital muscles, eyelids, dorsal plates, suspensory ligaments, and its attachment. So when I say orbital soft tissue, it includes orbital septum. So we have to divide this orbital septum into 2, external orbital septum and an internal orbital septum. The external orbital septum is a fibroelastic multi-layered diaphragm separating the eyelids from the orbital contents. So if you have to go into the orbit, we are supposed to cross this area, but making sure that it is intact. So when I say the internal septum, this has been explained well about Korneff in 1976 and Damer in 2002. It is an intimately linked framework of diversified connective tissue components, extends from an inner or visceral side of the periorbita to support the ocular globe. So we have to understand that it is not only the bone which supports the orbit, but also the septal system has a role in supporting or maintaining the position of the eye in the right place. So moving on, we have got the extraocular muscles. We should know about the origin, insertion, nerve supply, its relationship with the vascular anatomy. Only when knowing this, you will able to know or diagnose the right problem. So the last one is the bony openings of the small but very significant cavity, which is the orbit. There is fissures, foramina, canal, and grooves inside the orbit. The structures which are passing through these structures you should know right away about all these things. And moving on to the extraocular muscles, not only the anatomy, but also the physiology. How does it work? In what way it is related to each and every part of the orbit is something which we have to know. So the next one is something which every surgeon who is into reconstruction should know about it. So it is called internal orbital buttresses. So like any other buttress in the face, we study horizontal buttress, vertical buttress for our fixation of plates in the facial bone fractures. Same way, there is something called internal orbital buttress. In simple terms, they call it as struts. So there are 6 struts in the orbit. One is namely infromedial strut, posteromedial strut, maxillary strut, optic strut, lateral floor strut, and mid floor strut. Now that we are seeing the floor of the orbit, this picture, hope you can able to see my cursor here. You can able to see the infromedial strut, mid floor strut, and the lateral floor strut. These are all buttresses or bones which are there in the orbit, especially on the junction of medial wall and floor. In order to make sure that you place their orbital mesh or any other reconstructive material on these buttresses. This is one of the prognostic feature or those structures which, if present, gives you a better outcome when you go for reconstruction of the orbit. Coming to the basic classification of orbital fractures, these are the basic classification: Mansion et al., Converse and Smith, Hammer's classification, and Jackery et al.'s classification. Converse and Smith classified orbital fractures into pure and impure blood fracture. Impure fractures. Pure blood is again divided into 2: blow in, blow out. This is the internal walls of the orbit is fractured, but the rims are intact. Whereas impure fracture, it has got both the walls and the rim fracture. Coming to Jackery et al.'s classification, which is a very important and surgically useful one, is Jackery classified orbital defects taking 3 aspects, 3 criteria. One is size of the defect. Second one, location of the defect. Third one, absence or presence of the infromedial strut. So Jackery basically classified the orbital cavity into 3: posteriorly progressing, anterior orbit, mid orbit, and posterior orbit. Second, he divided the size of the defect from 10 to 20 millimeter squared, more than 20 millimeter squared. The third one, the most important aspect, is the presence or absence of infromedial strut. This is one of the strut which he has taken into account. So depending on the complexity, the reconstruction increases. For example, in class 4 or 5, the complexity of reconstruction increases. That is what he says. So this is the concise version of Jackery's classification. Coming to blowout fractures, the present pathophysiology is divided. The proposed pathophysiology is of 2 theories. One is buckling theory and the hydraulic theory. Buckling theory states that the fracture on the orbital walls undergo a rippling effect when there is a force on the wall, and the weaker portion, especially the medial wall and floor of the orbit, fractures. So this is buckling theory. The second one is hydraulic theory. It states that the pressure on the globe which is being transmitted into the walls of the orbit, fracture of the delicate portions, and it fractures as well.
Excuse me. Akhilesh, can you mute everybody except the speaker? Dr. Akhilesh?
Yes, sir.
Therefore,
Karthik, you can just unmute yourself and speak then. Now.
yes, thank you.
Okay.
Can you hear me, Akhilesh?
Yes.
When we consider the practical aspect of it, both the theories work because there is fractures which are directed to the globe, there are fractures which is directed to the orbits as well. So the most important or the fractures which everybody needs to know is called trapdoor fractures or white-eyed blowout fracture. The name white-eyed blowout fracture is because the subconjunctival hemorrhage, which is one of the clinical feature of orbital fracture, may or may not be there in trapdoor fractures, and mostly it is a surgical emergency. Though it is very common in pediatric population, it can happen in adolescent or adult patients as well. In this trapdoor fracture, when there is a force directed towards the globe or rim, the floor or medial wall opens up, which means gets fractured, and then the orbital contents go inside. Within a second, it snaps back, which means it locks the orbital contents below the floor or medial wall, which basically means there is a strangulation of the orbital contents, which can include muscle, septum, vessel, anything of such kind which has gone inside. So this is a very important feature because it is an emergency. It can lead to aclocardiac reflex as well. So this is one example of trapdoor fracture, what I have shown here. In detail, we'll see it later. So these are the signs and symptoms of orbital fractures. This may occur in isolation or this may occur in combination. So let us consider this this is a very important thing. Circumorbital edema and ecchymosis, subconjunctival hemorrhage, enophthalmos, hypoglobus, restriction of extraocular muscle movements, diplopia, paresthesia, and epistaxis. So here I have shown few cases of enophthalmos. Enophthalmos is the position of the globe going backward. So when there is an increase in the orbital volume, especially on the posterior side of the orbital volume increases, thereby the eye moves backward. This, in simple, this is called enophthalmos. There are a lot of papers which is stating that for every 1 ml of orbital volume increase, there is 0.8 mm of enophthalmos which is seen. So when do we appreciate enophthalmos? Only when there is more than 2 mm of enophthalmos, we can see clinically appreciable enophthalmos. Okay, hypoglobus. Now there is a vertical displacement of the eye. This is called hypoglobus. Enophthalmos and hypoglobus can occur together, or it can even occur separately as well. This patient, whatever I have shown, has got only hypoglobus, not enophthalmos. So when does the hypoglobus occur? When does enophthalmos occur? Is when there is a defect in the anterior floor of the mouth. Sorry, anterior floor of the orbit. There is a vertical displacement which ends up in hypoglobus. Whereas if the defect is posterior, it can end up in having an enophthalmos. Restriction of extraocular muscle. Okay, now you have to clinically analyze the movements of extraocular muscles in all 9 cases. If there is a doubt, then you have to do a forced deduction test to see whether it has got a mechanical obstruction in the movement in the specific muscle in which it is involving. Diplopia. Diplopia, it's a very complex phenomena. It is not as simple as double vision, because it can happen in a lot of situations. Basically, what a patient reports is a double vision. So there is monocular diplopia, binocular diplopia. As far as traumatic history is concerned, we are more concerned about binocular diplopia. In monocular diplopia, the patient may have an ophthalmic injury, which we are supposed to rule out. Coming to diplopia, broadly it is classified as mechanical and neurological. But if we go in detail about diplopia, so these are the causes of both monocular and binocular diplopia. It can happen in any of these conditions, of which mechanical and neurogenic is being stated here. At the same time, we have to understand that these are all the causes which can again cause diplopia. So emphysema, muscle edema, hemorrhage, hematoma formation in the extraocular muscles, any palsy of the nerve supplying those muscles, entrapment of inferior ocular muscle, inferior rectus muscle, entrapment of surrounding soft tissue, disruption of orbital septae, very important. Lack of support of the orbital contents, fibrosis of the orbital contents, fibrosis of the extraocular muscles. It can be even related to neurotrauma or intracranial cause. Out of all the causes, only three aspects can be treated by surgery. Entrapment of inferior ocular muscle, entrapment of soft tissue, lack of support of orbital contents. Only these three can be treated with surgery. All others, this cannot be treated by surgery. We have to be very clear about it. Coming to the clinical examination of a patient who has got an orbital trauma, we should divide it into three. One is clinical examination, second one is ophthalmic examination, third one is orthoptic examination. This orthoptic examination is little lacking from our part of the country. So the ophthalmic examination is an 8-point examination which has been recommended by the American Association of Ophthalmologists for a patient who has got an orbital trauma, which can again include orbital examination, visual acuity by Snellen's chart, ocular motility by force reduction test, and pupillary responses. The visual fields has to be charted with Hess charting, fundoscopic examination, Hertel's exophthalmometer to measure the enophthalmos here. If there is a fracture in the lateral wall of the orbit, then Nagel's exophthalmometer, something called a Nagel's exophthalmometer can be used. So, diplopia, the orthoptic assessment of diplopia itself is a big chapter. So there are a lot of devices like Goldman perimeter or binocular singular vision. All these things can quantify diplopia. This is important because only when it has been documented and quantified, you can able to assess the progress of diplopia on course of time. Tonometry, if you suspect a problem which is causing a retrobulb or hemorrhage, in case you should know that there is increased pressure of the orbit, and tonometry will give you the pressure as well. So this is the Snellen's chart for assessing the visual acuity. Force detection test. There are two ways to do the force detection test. One is having forceps holding the limbus, or the other one is holding the extraocular muscle which is of doubt or entrapped. So you can hold it in the inferior rectus, which is below the palpebral conjunctiva, or in the limbus, to move the eye in all directions, in all gazes, to note whether there is any mechanical restriction on such gaze. Basic diplopia charting. This is again very basic thing which is subjective. There is two lights which are used, red and green. So this can be done as a basic level. Hess charting for the range of movements of eye to diagnose the muscle action. Coming to imaging. So now that clinical examination, ophthalmic examination, orthoptic examination is over, you are supposed to have a radiologic examination. The CT is the gold standard for orbital trauma. That too, the slice which is 1 mm has to be visualized in all three planes, axial, coronal, and sagittal, to have a complete diagnosis as well as treatment plan, and to evaluate the prognosis as well. If there is a soft tissue injury in any of the periorbital or orbital contents, it is better to have an MRI and an ophthalmologist opinion to rule out anything of that sort. So this is an teardrop sign which we see often, or which we see in orbital floor fractures. So this is how it will look like. So there is a fractured floor here, and there is a herniated orbital contents. These are all coronal views. This is a sagittal view. Now, coming to the management of orbital fractures, you have diagnosed, you have now come to a point where you have to make a decision. So the decision is of three aspects: when to operate, how to operate, and with what to be operated. So this is an evidence-based decision making in orbital fractures. So again, it has been divided into four: immediate surgery, early surgery, delayed surgery, and late surgery. So what kind of fracture needs immediate surgery? Trapdoor fracture. It is worldwide, everybody has accepted that a trapdoor fracture is an emergency. At the same time, vertical globe displacement, other problems which can compromise the vision can also come into immediate surgery. Whereas the early surgery, which is within 2 weeks, inophthalmos, which is greater than 2 mm, and the fractures which comes under Jacqueries 2 to 4, with the restriction of elevation of 15 degrees, the abduction less than 25 degrees, or those patients who have to be taken up for surgery within 2 weeks. Okay, who are those patients which can taken up after 2 weeks to 3 weeks? Those who have got more inophthalmos, which means the patient has developing inophthalmos of more than 2 mm, the reduction is less than 8 degrees of improvement, or those patients which can be taken up after 2 weeks. The late surgery, again, late inophthalmos or persistent limiting diplopia. This term is little marginal. We'll discuss it later of this diplopia thing. Late surgery, which has got an orbital reconstruction, or which may also have a strabismus surgery as well. So this is the basic chart of evidence-based decision making and orbital fracture of when to operate a patient with a floor or medial wall fracture. So this again, it's the same, whatever we have discussed is the same here. So which comes under emergency? What kind of problems comes under an emergency other than trapdoor fracture? When there is a retrobulbar hemorrhage, when there is a see, these are all called orbital compartmental syndrome, because the retrobulbar hemorrhage causes an orbital compartmental syndrome. So these are the signs or symptoms of orbital compartmental syndrome, which has got progressive proptosis, decreased visual acuity, relative afferent pupillary defect, concentric motility impairment, pain, increased intraocular pressure, tight orbital tissues, chemosis, and decreased retinal perfusion. So both trapdoor fracture and which has got an orbital compartment syndrome. Akhilesh?
Yes, Karthik.
Yeah, can you hear me?
Yes, yes.
Yes, thank you.
But could you just put it on full screen? Yeah, now it's full screen.
Yeah.
No problem.
Yes. So this is the decision making for orbital fracture repair. So now that we have decided to go on with the surgery, so these are all things which we have to consider before operating. So now that CT is taken, we have to read the anatomy of the fracture pattern. Soft tissue assessment has to be done. Right diagnosis and treatment plan should be ready, and we have to decide on our approach, the material which we are going to use, or any other system which we need for the orbital surgery, like endoscope, navigation, virtual surgical planning, all those things. Broadly, we can classify the surgical approaches into two. One is transcutaneous, the other one is transconjunctival. Here, the approaches is being divided according to the area of exploration. For example, if you are approaching the rim, inferior orbital rim and floor, in transcutaneous, either you can use subciliary, subdorsal, or infraorbital. In transconjunctival, it can either be preseptal and postseptal. Transantral, of late, not much of use, exclusively transantral. Whereas in supraorbital orbit, supralateral orbit, you can use either a lateral eyebrow, supratorsal fold, or a coronal approach. Medial orbit, it can either be an extension of a transcutaneous with transcaruncular approach, or a Lynch incision, transnasal approach, and coronal approach. So two factors has to be considered. One, the expertise of the surgeon. Second, the area which you are supposed to explore. So how far it is from your, how far it is from the reach of your incision is something has to be considered before selecting a surgical approach. So explaining about these incision here. Subciliary, subdorsal, and infraorbital. About subciliary incision, again, it can be divided into three. It is non-stepped, stepped, or skin-only flap. So it depends on what are the structures which you are dissecting to go to the infraorbital rim and the periorbita. So this is what is called stepped approach. This is all steps for subciliary approach. So either it can be a stepped one or non-stepped one. Whereas in mid-tarsal or subtarsal approach, the incision is through the skin and muscle. Hope you can able to see my cursor here. The incision is here. That it incises the skin and the muscle. At the same time, the white layer here is the orbital septum, which you don't disturb it. So you go under this, go to the infraorbital rim, then incise the periosteum. So now you are entering into the periorbita. Same way, transconjunctival approach. So transconjunctival approach can be added with lateral canthotomy and inferior cantholysis. Only then you can able to have a good amount of exposure to the floor and some amount of medial wall. If you are adding up your transcaruncular, you can go up to the posterior aspect of the medial wall. So this is something which is of paramount importance for people who are into the orbital dissection, surgery, or reconstruction. The first picture tells about some topographic values of measurements of the vital structures inside the orbit. How far is it from your infraorbital rim or anterior lacrimal crest or your frontozygomatic suture? For example, here in this first picture, what they have given is the measurements of anterior ethmoidal foramina and posterior ethmoidal foramina. So from anterior lacrimal crest, these values are very, very arbitrary. This can be as a guide, but this is not the same for everybody. Anterior ethmoidal foramina 24, 12, 6. The 6 is the optic nerve. Whereas from the infraorbital rim to the optic nerve, it can be up to 42 mm. So this one, the white line here, which is shown here, is the strut which we were talking about. So the one inframedial strut. So how far it is from the orbital infraorbital rim is what is being shown here. So the defects, the zones here. In the next picture here, this is the sequence of dissection. When you are exploring the orbital floor and the medial wall, this is the sequence of dissection. What does this dissection signifies is, this is all little, these are all areas which is supposed to be little stronger, or you can have a consistent landmarks for you to dissect the complete orbit. So I hope you're all seeing the second picture here. This 1, 2, 3, 5, and 6. So this indicates the stepwise progression in numerical order. For example, this is again stating the zones of bleeding. This blue zone may have a branch from the maxillary artery. We are supposed to expect that there can be a bleeding in these 4 zones here. In blue zone, there can be a branch of maxillary artery. In yellow zone here, which can have a branch of infraorbital vessels. In green zone, there can be branches of antral mucosa. In red zone, you will be having anterior and posterior ethmoidal vessels here. So you should know how to progress posteriorly and what to expect, how to control the bleeding as well. So what does literature says about these approaches? Both approaches have its own disadvantages. The subconjunctival approach had a significantly higher incidence of entropion than the subciliary approach. So that is what has been stated as far as the literature goes. Coming to the biomaterial. So what is the biomaterial we can use for an orbital defect, especially on the floor? So these are all the ideal properties of the biomaterial which is supposed to be used, and none of the biomaterial will have all these properties. So you are supposed to choose a biomaterial depending on the size of the defect and the complexity of the reconstruction. So these are the factors which influence the choice of biomaterial. One is size of the defect, involvement of either single wall, double or multiple walls, adaptation to internal contours, restoration of proper volume, presence of adjacent sinus cavity, prevention of displacement, risk of further trauma, or early versus late repair. In which stage are you in? Is it a primary repair or is it a secondary correction? Adhesions and restriction of ocular motility as well. To concise, to put it into a single table, what will be your material of choice? Say here, in first column, it has been shown as the number of walls. If a single wall, if it is a trapdoor defect, in fact, there are people who say there is no need of any orbital reconstruction for trapdoor defects. But you put anything, it works because the defect is very minimum, or it is a linear defect, or it is more anteriorly present. So single wall defect, if PDS mesh is enough. Or single wall loss of contour, you can have a pre-shaped titanium. Floor and medial wall, again a pre-shaped titanium. But when you approach more posterior, it is better to have a anatomical mesh or a custom made mesh, and it is better to have a intraoperative navigation as well, because beyond 30 mm, 35 mm, it is not recommended for you to use your retractors against orbital contents. The pressure of the retractor itself in the posterior orbit can cause trauma to the optic nerve as well as the extraocular muscles. So this is the basic idea of the material of choice for floor of the orbit. So coming to cases, I'll be showing few cases for us to just see how does it, a simple and straightforward cases where everybody can understand. So this boy presented after 10 days of trauma. He went a lot of places, but his problem was restricted eye movement and diplopia, but he came only after 10 days. So you can able to see a very significant trapdoor fracture on the floor of the orbit, restricted eye movements, diplopia in all cases is what we need. So we made all CT examination, diplopia charting shows all cases he has got a diplopia. So immediately he was taken into surgery. So this was done. So once the entrapped muscle and orbital contents were released from the linear trapdoor fracture, the antral wall itself was used as a reconstructive material. So this is an endoscopic image of the content inside the antrum, which is below the floor of the orbit. you can able to see the part of the inferior rectus muscle has started to necrose. So that's because he has reported after 10 days. This is a venous congestion what we see. So that is one of the very important reason people say that it has to be operated immediately. So the more late you operate such patients, the outcome will be little compromised. So again, these are all the images of the same patient. In the last boxes here, you can able to see pre and post of how the entrapped contents. So this is the big congested and entrapped orbital contents with inferior rectus, septae, all those things are there. Once it is released, you can able to see the floor of the orbit here. This is a post-op X-ray. Again, the recovery of diplopia. How did the diplopia recur? For this patient, he had definitely a better vision or absence of diplopia in both the straight gaze and the superior gaze. But he still had a diplopia in the downward gaze. This is the range of eye movements from how it was to how it is now after 6 months. You can able to see the difference in the range of eye movements, but still it is not complete, which is there is some amount of restriction, which is because of the late reporting. Same trapdoor fracture, but the reconstructive material here, what we used is the titanium mesh here. So there is something called enlarging the defect, because the orbital contents is strangulated between the elastic bones. That is better not to squeeze those contents through a very narrow space. If possible, it is better to increase the orbital defect, nothing wrong in it, because you don't want to squeeze the orbital contents out of the small defect there, because that itself will cause a lot of injury to the inferior rectus muscle and the orbital contents there. So increase the defect. The defect, now that it is a single wall defect, a more anterior, a normal titanium mesh is enough for covering the defect. This boy, it is an impure blood fracture. When there is a case of impure blood fracture, the surgical sequence is to make it pure. So what do you make it pure? You are supposed to plate all the orbital walls into the right position. Only when it is in the right position, then you can consider reconstructing the orbital walls. So this boy, he lacked a lot of bone in the infraorbital rim and floor. So together he was reconstructed with an iliac bone, both for the rim and the floor. So disadvantage of this reconstruction is we cannot contour this. So we all know that there is something called a Hammer's area, which is on the posteromedial aspect of the eye, which gives the projection of the eye. So in the next case, we will see that. But this is the disadvantage of having a bone graft, which cannot be contoured to the right anatomy of the orbit. But still, this patient had a better outcome from what he was to what he is now. Coming to the last case of this presentation, from whatever we have seen, let us have a treatment plan with this lady. So she reported with trauma to the left eye. She developed early inophthalmos of 4 mm within 3 days. Within 3 days of trauma. So she comes under the category of early repair. So coming to the CT examination, what we see is the defect in the coronal region and the sagittal region. Here, what we are supposed to see is the presence or absence of the infromedial strut here. Here, this is this bony thickening here. What you see is the infromedial strut. What you see here is the Hammer's key area. So both are present, which is of an advantage for us to have the right reconstruction. So this is what is being done for her. Again, dissection completely into the defect. So what I have done is measured the defect from the infraorbital rim to the posterior most aspect of a stable bone or Hammer's key area. So that is where we are supposed to place this mesh now. So I have measured it, made sure that the mesh which I was using has gone to the sufficient length to cover the defect. This is the medium size mesh of striker. If you see the scale here, this flexible scale here, you can able to see the defect side, the posterior area which we are going to place the mesh is 30 mm. You can able to see here the total length of the mesh is again 30 mm. Only when the mesh is completely inside, you can able to cover up the area, cover up the defect, as well as place the mesh in a stable bone. So that is what is being done in next cases. So 1 second. Akhilesh, can you able to see?
Yes, yes.
This is an endoscopic view of the same patient, whatever I have shown you. So this is the one, the vascular structure here, white vascular structure here has got the neurovascular bundle of infraorbital nerve and vessels. So you can able to see the orbital contents here, lateral side of the nose and the infraorbital nerve with vessels. So you have to be very careful about preserving those structures as well as taking the whole orbital herniated contents superiorly. Yes, this is the whole defect what you see here with the displaced infraorbital neurovascular bundle. Yes. I'll show the intraoperative placement of mesh after retrieving the orbital contents. Yes, here. So there is, this is the one which is here, the infraorbital region. Posteriorly, when you approach, your defect is seen, the mesh which you have placed is seen. But there is a problem here. If you see clearly, the mesh is not adapted to the posterior ledge properly. You can able to see it is slightly sticking out of the difference between the floor and the mesh. These kind of reconstruction will end up in having a restriction ocular motility post-operatively, because the mesh which we are adapting has to be on par with the orbital floor, at the same time has to be landing on the posterior ledge here. So this is one of the advantage of having an endoscope intraoperatively. Where you can able to see the position of the mesh, adaptation of the mesh and everything else even after placing it. So usually that will be a little difficult because you never know what has stuck between your mesh and the defect. Whether the defect is completely covered with the mesh, whether is there any restriction posteriorly to the mesh is something which you have to be very sure of. So these are all endoscopic images, and what is stated in the literature.
Sorry to interrupt. Could you just make it full screen again?
Sorry, we are about to complete. Yeah, this is the literature about endoscopic measurement. So coming to the patient specific implants, if the defect is more, which means the if it is involving multiple walls and the size is more, and if it is posterior, it is better to do a patient specific implants with virtual planning. And if it is better to have an intraoperative scanning and navigation if you can able to afford it. That is the whole area. To compile the complications, it is early and late. This complication is different from adverse outcome. This adverse outcome is because something wrong which we have done. Early complication include edema, infection, wound adhesions, aberrant implant position, which I showed you, extrusion of implants, Late complications include persistent enophthalmos, persistent worsened diplopia or altered vision, restricted ocular movement, and fibrosis addition. Whether their adverse outcome can be entropion, hypertrophic scars, change in the axis of the palpebral fissure. So let me conclude like this. The right anatomical reconstruction of the orbit does not guarantee you the right or all good functional eye. So even though you reconstruct with 100% anatomy, not in all cases you can expect to have the 100% outcome. So which are the factors which is making this things go wrong is something which is again a different seminar. Thank you all. Thank you for the opportunity again.
Thank you, Karthik. I think the participants can share their questions in the chat box. Binu sir, I think there are 1 or 2 questions in the chat box.
I can see one question here. How will you deal with enophthalmos secondary to soft tissue volume loss? You have, when the skeleton has been restored to pre-trauma anatomy.
Yes, sir.
And you would also like to know which angle rigid endoscope do you use?
Yes, sir. Sir, what I have used is a 4 mm 30-degree endoscope. The question is very important because the soft tissue loss is not been, you cannot predict the soft tissue loss irrespective of having a orbital reconstruction. As sir asked, like when we do a late reconstruction, the volumetric analysis will help you to have a right volume on the affected eye. Thereby, using a custom-made implants will give you such volume to compensate the soft tissue loss as well.
Yeah, how do you that? The soft tissue loss? Because you are getting this CT and
Yes,
then finding the orbital volume on the unaffected side, and on the affected side, you are. I mean, how do you assess the volume of the soft tissue loss?
Sir, that soft tissue loss is something which a lot of researches has been done. For example, they are calculating the loss of herniated volume, and there are articles which are calculating the increase of orbital volume. They say that when you calculate the amount of orbital volume which is herniated, the prediction can be more. But when in general, this is something which is arbitrary, which cannot be calculated because it may be progressive. It depends on the amount of trauma to the eye, the fat atrophy, all those things cannot be predicted. What we can do is to do the right anatomical correction and wait for the outcome.
Okay. The next question is, after intraorbital fracture treatment, patient complains of teardrop occurring. I think it means that tears are coming.
Yes, sir. So nasolacrimal system, which is of very important aspect when you approach a floor. Preoperatively itself, you have to make sure that whether your nasolacrimal system is intact. Only then you are supposed to go into the orbit. If you are iatrogenically damaging the nasolacrimal system, then it is better to have a opinion from the oculoplastic surgeon to repair the nasolacrimal system, which can be a cause of tearing of the eye. Immediate tears will be there immediately after surgery because you have manipulated the orbital tissues a lot. So immediate after the surgery, there will be tears. But if it is from the nasolacrimal system, then you may have to go for a secondary repair.
Karthik, just a request. Could you just stop sharing and switch on your video, please?
Yeah, 1 second.
Hey, Sadish, hi Sadish. Sadish, I again would like to know whether the PSI will restore volume. I think that's your question, right?
Yes, that's my question, because we were having problems with volume restoration. I thought maybe somebody could give us some fresh ideas. Thank you for the lecture.
Okay, the next question, thank you, Sadish. The next question is this. Do you have something to say about PSI?
Yes.
Hello, Karthik.
Yes, as the Dr. Satish asked, there has been researchers which
Hello,
were.
Karthik.
Yeah. Can you hear me, sir?
Yes, yes.
As Dr. Satish asked, there are researches which were done to increase the soft tissue volume by injecting some amount of fat into the orbital space with the orbital reconstruction as well. But till now, there is no evidence to do all those things. Till now, we rely still on PSIs and virtual surgical planning.
Okay. We go to the next question. If vision is lost with or without globe injury, is orbital floor reconstruction necessary?
Yes, even after the vision loss, for you to have the right anatomical contour for the future processes, it is necessary.
Because we have to rehabilitate the patient, so we need
Yes.
some sort of a place where we can put a globe prosthetic eye, right?
Yes, sir, exactly.
The chance of visibility loss or injury of optic nerve during reconstruction of orbit. This is the next question.
Yes,
What
sir.
is the chance of visibility loss or injury to the optic nerve?
So it is the worst case scenario. Like it's if you are going into the posterior orbit blindly, there is more chance for you to injure the optic nerve. Or if you are injuring a vessel which is in the posterior orbital space, there can be a problem with the optic nerve. Or if you are handling the soft tissues intraoperatively with a lot of pressure, there can be a chance for optic nerve damage. Recently, I did something on the orbital retractor with the pressure sensor, because when we are operating, we are having our globe under our retractor for a lot of amount of time. We did a study on the measuring the intraorbital pressure both before, during, and after surgery. There was a gross increase during the surgery. So all those things should not be done. If you are so that is what you are supposed to do for not to injure the optic nerve. Optic nerve is something which is difficult to reach. If you are going blindly beyond 35 mm in the posterior orbit on the floor or medial wall, then there is a chance for you to injure the optic nerve.
Yeah, another technique is to always stand behind, on the head, near the head end of the patient.
Yes,
That
sir.
is behind the head end. So it's highly improbable to go near the optic nerve. You can go to the place where we can find the ledge, and then probably repair it and stop your dissection till that area. So it's always safer not to stand on the side, but on the when you operate in the orbit, stand in the head end.
Yes,
So
sir.
you are unlikely to go towards optic nerve. The next question is, what endoscopic approach is preferred for surgical repair?
So, as maxillofacial surgeons, it is better to have a transantral endoscopic view. That will give you a beautiful view of what is happening in the floor. So, as I said, I used a 4 mm 30-degree endoscope. So, that gave us a beautiful view, which was difficult to see through the orbit. So, as we talk, the posterior ledge is, the average length of Hammer's key area from the infraorbital rim for males is 33 mm. For females, it is 32 mm. So this is little difficult to find through the orbit, because all your orbital contents are there. Whereas if you go through the endoscope, posteriorly, you can able to find whether there is one such thing or not, or if whether your mesh is been there or not, which is relatively easy. So endoscope assisted orbital floor reconstruction is something which is better than exclusive orbital approach.
Okay, the next question is surgical management of retrobulbar hemorrhage. Can you comment on that?
Yes, orbital reconstruction with lateral canthotomy. So that is one of the immediate surgical intervention. which we can do.
Okay. Again, a comment on ocular cardiac reflex. Your
Yes.
experience.
Sir, oculocardiac reflexes, yes, this can happen in lot of cases where we manipulate the entrapped vessels. A small surgical tip would be to give an LA on the nerve, on the muscle which you are manipulating, or on the base of the surgical orbital contents which you are doing. That will actually reduce the chance for oculocardiac reflex.
In one more question, this is on post-op care. Any
Yes.
advice for that? And
Yes,
how
sir.
long to keep the tarsorrhaphy? Is it required? Post-op care?
Yes, sir. Tarsorrhaphy, what theoretically they say to keep it for 1 week to 10 days, but practically there is no need for you to have a tarsorrhaphy if you have done your dissection with softly and in the right place.
Okay.
You can use tarsorrhaphy intraoperatively, but post-operatively that is not necessary.
Yeah, again, it closes the eye, so it may be difficult for us to examine the eye also, right?
Exactly, sir.
Somebody wants to know here again, Mithilesh wants to know whether to suture the transconjunctival incision.
Absolutely, yes.
better to
There are
suture
again
the-
studies which does not sutures it, but it is better to suture the transconjunctival incisions as well using either a 9-0 or 10-0 suture material.
Okay. Here, they are giving us, he's giving a scenario, Dr. Jinsi is giving a scenario. The patient has sphenoid fracture line extending to the optic canal, and the patient loses vision within 12 hours of injury. But the patient had no diplopia or nor vision loss when the patient was brought into the casualty. What could have been done so that the patient do not lose his vision? I hope you got the question. Or did you get the question?
Not exactly, sir. The patient has lost his or her vision, right?
Yes.
So, we see there is something which is called traumatic optic neuropathy, which we have not spoken about. The basic thing, if you are suspecting a traumatic optic neuropathy, then a megadose steroid can be of choice.
Okay. Okay, this concludes. I mean, these are the questions on the plate, on the posterior, the plate or the mesh sitting up from
Yes,
the
sir.
posterior ledge. This can sometimes happen when we tighten the screws. We have placed the mesh properly on the ledge, but sometimes no. Once we have adapted the plate and kept it on the posterior ledge, and then when we are screwing on the in the inferior orbital margin, once the screw tightens, the plate can sometimes just
Lift up.
rise up a little bit.
Yes, sir, possible.
Kept it very properly, but when we tighten, probably the mesh is also malleable. So sometimes when we tighten, the mesh can lift up from the place where we are kept. So that is one thing which sometimes we may miss. We have done everything, but in the post-op X-ray, we will have a heartbreak that we have done everything, done all the hard work, but you can see the mesh sitting a little up.
Yes.
This is something which sometimes can happen. So we have to be careful when tightening or adapting the mesh or the screws when we are tightening it up. So this can sometimes happen. Can you, I mean, the next question is, can you elaborate on megadose steroid? Megadose steroid. This, I think it's something which you have talked about, I mean, regarding this traumatic optic neuropathy, or can you, so somebody's asked about elaborate on megadose steroid. Karthik, did you get the question? Hello?
I think he's having network issues, sir, because it's it's back online.
Okay, I think.
Let's repeat the question for him, sir.
Karthik, can you elaborate on megadose steroid?
Sir, it is not under the topic of this thing.
Yeah.
Ah,
Okay, so again that we have already gone to 10 o'clock now.
yeah.
Maybe we could have another talk on this.
I can share the presentation with Dr. Akhilesh, like what is the protocol to treat traumatic optic neuropathy and retrobulbar hemorrhage suggested by American Association of Ophthalmologists.
Very good. Thank you.
Thank you, sir.
That's wonderful.
Thank you so much, sir.
Anybody else has got any other questions which we can take it up? I think somebody has asked about trans. Is it Akhilesh? Is it time to wind up, or can
No,
we take
no,
up
I
some
think
more
we can,
questions?
if it's okay with Karthick, then we can have 1 or 2 questions, sir. No problem.
Transcancer
problem.
nasopec.
Yeah.
I think it is transcanthal nasopexy.
Yeah.
Yes.
So the pexy is something which we repair the ligament. So mostly the lateral canthal ligaments are much more intact because it is attached to a very stable structures of like a Whitnall's tubercle. So when there is a naso-orbito-ethmoidal fractures, there can be a severance of medial canthal ligaments. So in such cases, you can do a medial canthopexy. So if that is what has been asked, if is there, can it be done through transcanthal approach? I don't have a personal experience on that, sir.
Comments coming up regarding your lecture, and many people have commented saying that it's a great lecture.
Thank you, sir. Thank you.
There is another question which has come up now. Orbital cases of panfacial fracture. I think you have touched upon it because you have said how to convert it into a pure broad fracture.
Yes, sir.
Again, do you have any further comments on this, or what about it's written?
What we talk a lot about is the reconstruction of the orbital walls, but absolute reduction of the orbital rims. For example, lateral canthal, lateral wall of the orbit, if it is not reduced properly, then the outcome would not be better. So absolute reduction of the orbital rims is as important as reconstruction of the orbital walls. So that is what I have seen. Like when I see the patient with a lot of orbital dystopia and a minimal amount of orbital displacement, after right reduction, the eye position of the eye comes into the right place without even orbital reconstruction. So that is something which have to be done, has to be done.
Okay. I have one doubt.
Sure, sir.
If we don't have the posterior ledge, like you said, the posterior ledge is missing.
Yes, sir.
How do you find that area where to put
Sir, people again in the literature, they are suggesting us to have a PSI. Which has got a better strength, which is again a contour to mimic the posterior ledge. So if we can able to have a PSI which can mimic the posterior ledge, that is the only option we have. Or to take support from the other walls, whichever is intact. Or as I said, there are a few other struts which we can take support from. That can be done. When there is no such thing, either an PSI or an anatomical 3D mesh would be of the right choice.
So if maybe in this cases a navigation comes in handy, right? So where we can end the mesh posterior.
Yes, sir.
The mesh.
So what I Sir, we don't have a navigation. I have not used navigation personally. So what I did was to customize the instrument to have a marking. So when I did that, I know where I am going to, which length I am going, all those things. So that is something which I did on which laser marked the freer retractor, freer elevator, freer orbital retractor. So from the rim, if I go, I know, okay, this is the safe zone where I can go. So that is something which I did personally.
Here there is one more question that has come up. Can you elaborate on the real-time feasibility or the ease of identifying the fourth dimension of stability intraoperatively?
I don't exactly understand the question. What do they mean by fourth dimension of stability? Akhilesh, can you help us?
And,
No, sorry, Karthik, no idea. I am not sure what exactly is meant by that question.
Yeah.
For real-time feasibility research. No,
Fourth
no idea.
dimension of stability. What does that mean? I don't know.
Anybody wants to ask some?
Yeah, anybody from the audience can answer that. There are many senior faculty here, so anybody else, if you know the answer, you can just answer that.
After transantral endoscopic approach, do we need an antral support? Yes. Yeah, if you're the same, the bone which you have removed can be placed back. That is something which you can do. If you are not, if it is not in the right shape, then you can have a small mesh on the antral defect which we have created. Personally, I have used the same bone window which I have opened can be placed in the same side, which means the gap, the antral defect can be closed with the bone, same bone.
There are many people who are commenting on your lecture. They are.
Thank you, sir. On a lighter note, hope did you see that the Manjumal Boys movie, sir?
No, I have yet to see that, but I think I mean, most of us would have seen that.
The thing is like
it is a hit movie over here.
Orbital defect is like a Guna cave.
It's coming now.
What can save you is the ledge.
Exactly. Yes. That makes your life easier. Again, one more question. First year ledge is absent. The rest second nerve is more perhaps. That's what Sadish wants to say.
Yes.
Sadish sir, please feel free to unmute yourself and speak, sir, if you need to.
Thank you. I think I will text so that everybody can see questions.
Okay, he wants, I mean, Sadish, you can go ahead and ask this question again. His direct vision, Sadish, can you go ahead and ask
Karthik, I just
question?
wanted, I know it's late in the evening, my apologies.
No issues.
I just wanted to know if you ever tried to visualize the second nerve directly when there's no ledge.
No, see.
Because positioning the PSI or whatever you want, any rigid implant, right at the back has its own problems. If you have a ledge, you can sit it on the ledge, but if you don't have a ledge, especially the iota of trauma, when if there is no ledge, means it's a massive fracture. It's not going to be simple.
True, very true. On that aspect, we are relying on the virtual treatment planning, which we have done. So if the PSI sits in the right place in the infraorbital rim, then we assume that it is not beyond the problematic zone.
Did you ever try visualizing the second nerve through the nose, making a hole into the medial through the nose using a rigid endoscope?
No, no, I have not done that. But let us understand the end of the maxillary antrum is not the end of the floor. So what we can see is the maximum posterior ledge from the antrum. Beyond that, there is orbit, but there is no
That's
antrum.
why I asked, have you ever tried going through the nose?
No.
You know, going
I have not done.
intentionally making a hole in between
Yeah,
this
no.
midal posterior.
For medial wall fracture, there is something which we have done with the help of an ENT through the ethmoid. Through the ethmoid, we tried to see whether the mesh is in the right place and things like that.
Thank you so much, and thank you,
Thank you, Satish.
for the lecture. Fantastic. Thank you.
Thank you.
There is one more last question. Any experience on reconstruction with auricular cartilage?
Yes, sir. I have done auricular cartilage reconstruction. So again, as I said, simple, straightforward, smaller defects, you can place whatever you wanted, whichever you have the expertise in harvesting. That works. But beyond a point, if the defect is large, then or posterior, the articular cartilage does not work. It neither has the stability nor has the character to be adapted.
Okay, so you mean to say that it can be used in a trapdoor or a small defect fracture,
Exactly,
right?
sir. Exactly. Anterior floor of the mouth, yes. Floor of the orbit, sorry.
I think we can take this one more last question. In case of orbitozygomatico-maxillary complex fracture, combined leaford endoscopic assisted surgery possible? Orbitozygomatico-maxillary complex fracture.
Possible if you have.
Much from that.
Thank you.
Okay, Akhilesh, I think is it?
I think we can wind up, sir. Yes, sir. So we have come to the end of our session. If you have any more doubts, please feel free to share it with me, and I will forward it to Karthick. And once he shares all that American Ophthalmology Association protocols, I'll share it in our groups and I'll send it to whoever sends me a request. And thank you, Binu sir. Thank you for moderating the session, and thank you, Karthick, for a wonderful lecture. I'm sure that we all have got something. Like you said, it is a mixed crowd, and everyone has got something to take home or go explore something more further in orbital trauma. So thank you very much for your lecture, and I thank all the participants for your patient listening. Thank you all.
Thank you, Karthik. Thank you. It was very wonderful.
Thank you, sir. Thank you, Akhilesh. Thank you, Binu sir. Thank you, Kerala AOMSI. So 150 participants. Thank you all for a late night lecture. It is a big crowd.
Yeah.
Thank you, Ra.